to have Dr. Tiffany Wong. She is a pediatric allergist at the BC Children's Hospital, and her team we're doing a delabeling project called Drop the Label, which is the name of the series today. And it's to help with penicillin allergy delabeling. I'll pass that over to you, Dr. Wong.
Wonderful. Thank you, Holly, for the kind introduction. It's been such a great experience working with the Firstline team and everybody else who's been involved. So thank you for having me share my experiences and our product with you today. My whole platform has been that penicillin allergy delabeling truly is for everyone. You don't need an allergist. We are trying to put me out of a job here when it comes to penicillin allergy delabeling, and make space actually for the patients who do, have legitimate allergies and need complex treatment. So in the way of disclosures, I am very generously funded, not so much industry-wise, but through our hospital facility engagement funding to do this work, and by the Doctors of BC. I have a unrestricted educational grant from ALK that helps to cover the cost of the independent website that we've created. For this session, I will briefly review some of the evidence behind beta-lactam allergies and the assessment, and then hopefully give everyone an approach to addressing beta-lactam and or penicillin allergy labels in day-to-day practice. I'm hoping by the end of this, those who are attending or listening will be able to start identifying opportunities in your local environment for delabeling penicillin allergy in your patients. So my work started really with this one patient we'll call Anna early in my practice. She was like hundreds of others that I've seen. At 2 years of age, she got an ear infection and was prescribed oral amoxicillin. Whether she needed it or not was, another discussion. But after she started the amoxicillin, she developed a delayed maculopapular rash, much like the one you see on this photograph. She was labeled with a penicillin allergy and sort of went on her way. This is an infographic produced by one of the medical students I worked with. So she got her penicillin allergy label and then went along for many years having this allergy unquestioned. So anytime she got an ear infection, she got a different an alternative antibiotic. And was fine until she showed up at 12 years of age with strep throat infection. So instead of penicillin, she was given clindamycin, and she subsequently developed C. diff colitis and had such high output that she developed hypotension and renal failure and required an ICU visit. So it was really striking case. Because most patients, they get a rash and it goes away, but she really had a significantly bad outcome. Going back to drug allergy in general, it is a very specific term and requires that the reaction involves the immune system, and they are unpredictable. So it's not the same as side effects, which are predictable. Drug allergies, when we assess them, we have the Gelling-Toombs criteria, which is a bit it's a bit broad, but I think practically speaking in clinical practice, it's helpful to divide them into immediate and non-immediate. So the only truly immediate reaction is IgE mediated, which is type 1. And this is the one that most people worry about when we talk about drug allergies. The others, type 2, 3, and 4, are typically quite delayed and have presentations that cannot be mixed up with IgE-mediated allergic reactions. So I'll focus on the immediate allergies for the purposes of this presentation. They really do require prior exposure to the medication in order to trigger this immune response. So if it's the first course ever you're having the amoxicillin or other beta-lactam antibiotic, it's extremely unlikely that you're allergic, no matter what symptoms come up. Symptoms present immediately within 2 hours after ingestion of the medication, but very typically, usually within an hour or even less. And then the picture here describes the symptoms you could get. So urticaria, angioedema, cough, wheeze, shortness of breath, hypotension, or GI symptoms. You can have these in combination, and that would be called anaphylaxis. And if you take the medication away, the symptoms should resolve within 24 hours of stopping the medication. So these are key features that a lot of people are not familiar with, and this leads to the misdiagnosis of allergy. Maculopapular rashes are not a feature of IgE-mediated allergy. The character is not typical, and the timing is also not consistent. So everybody on here, I think, is fully aware that penicillin allergy labels are very common. About 10% of the North American population reports that they're allergic, and 75% of these allergy labels are acquired by the time we're 3 years of age. However, of the 10% who think they're allergic, 90% of these individuals are not actually allergic when they're assessed by an allergist and are able to tolerate the penicillin or other beta-lactam medication. And in Canadian pediatric studies, up to 96% of the children are able to tolerate the penicillin or amoxicillin. Severe reactions are very, very rare, and they were thought to be more common in previous decades where IV penicillin was much more commonly used. So why does this happen? Why is there such a discrepancy? And why did these other people who are labeled with penicillin allergy get labeled even though they're not allergic? So far and away, the most common would be miscategorized symptoms, symptoms of the infection itself. So for example, pneumonia and shortness of breath or tachypnea, those could be miscategorized as an allergy if things seem to get worse right after the medication is taken. Side effects of medications are often confused with drug allergies, when in fact it's a different category of adverse effect. And infectious exanthems. So many infections are associated with rashes, and they're often erroneously contributed or attributed to the antibiotic instead of the actual infection. So there are patients who have never been exposed, but they have a family member who has been labeled as allergic to penicillin. We know that, okay, well, most of these patients are not allergic in the first place, the family member, but even if they are, we don't inherit this risk of drug allergy the way we inherit the risk of other allergies like food allergies. In some countries, skin testing for penicillin is very commonly used as a screening tool, but they are not good screening tools because we have a lot of false positive results. And fear and anxiety. So even if a clinician, pharmacist, or other healthcare professional hasn't labeled a patient with a penicillin allergy, fear and anxiety often drives these labels, and often we'll see that they are labeling themselves with a penicillin allergy. So Anna could have possibly been, treated effectively with penicillin, but she wasn't. Now, I know that the risk of C. diff is always present with antibiotics, but perhaps we could have prevented her ICU visit by using the most appropriate antibiotic and avoiding clindamycin in her case. So she's really the impetus for all of this work that I've done with the whole team in the last few years. We know that penicillin allergy, when erroneous, is a public health problem. It leads to poorer care and poorer outcomes by the way of using more antibiotics, more broad spectrum antibiotics, and second or third line antibiotics that don't work as well and might lead to adverse events, longer hospital stays, and also antibiotic resistance. There's really great evidence for the increased cost of hospitalization if we're using alternative antibiotic therapies in different countries across the world. And so, we have an abundant evidence of this public health problem, but what do we do about it? So what we need to do is create awareness and question the diagnosis. And that's where penicillin allergy delabeling comes in. So what is that exactly? When it first came to life, it was a very stringent process. So you had to take a medical history, and then you had to do the skin testing, and then you had to do an oral challenge in the patients who were considered low enough risk or had negative skin testing. And the goal of these programs is to find the patients who can safely receive the penicillin and other beta-lactam antibiotics. It is typically multidisciplinary, involving antimicrobial stewardship teams. And those teams are made up of pharmacists, physicians, they could be infectious diseases doctors, pediatricians or internists, and sometimes and often involving allergists as well. And again, we have good data that penicillin delabeling is effective, and it reduces all of the problems that we see with erroneous penicillin allergy labels. And so this is great if you work in an institution where there's a lot of help and a lot of specialized resources. But what about everyone else? What if you work in none of it and you don't have a specialized team, or you work in a small hospital and there isn't an infectious diseases doctor or an allergist who is less than 4 hours away? And so I'm here to tell you that penicillin allergy delabeling doesn't actually, you don't need a specialized team. In most cases, skin testing isn't necessary. There's a high rate of false positive results, as I've mentioned. And recent studies, particularly in pediatrics, show that they're not really all that reliable to begin with, even in patients who do have allergies. So you can assess risk in any setting by taking a really good medical history, and oral challenges can be done very safely as well, because most of these patients who are low risk are truly not allergic. And so that's something to remember when we're thinking of penicillin allergy delabeling. Most of us are so hardwired in our training to avoid medications when patients state they're allergic because we're afraid of the consequences. And so this does require a bit of a mind and culture shift. Assessing the risk of beta-lactam allergy is really quite simple. There are only a few key questions you need to ask. And once you have the answers, you can stratify risk. So high-risk patients are the ones where it sounds like they've had anaphylaxis, they've had severe cutaneous reactions or systemic symptoms and needed a hospital admission. And so these patients, you should absolutely be avoiding the medication, picking some other alternative medication, and referring to an allergist. The patients that are low risk are the ones who've had these delayed mild rashes. It sounds like a side effect and not an actual allergy. Patients who are avoiding based on family history only. And if they've had the medication again and tolerated, they're not allergic. And so these patients can be delabeled, and you can give a test dose in office. And so we have risk assessment algorithms. This is very common in medicine to have these flow charts and help you arrive at a decision. This was published in the Canadian Pediatric Society as a practice point in 2020, and it was determined to be validated in a previous study coming out of our hospital to be reliable in identifying low-risk patients. There are many of these that exist in the literature. This one is from the Canadian Society of Allergy and Clinical Immunology, and essentially, leads you through a same process as the one as I had in the last slide. And then this is a very popular one from JAMA Internal Medicine. This is from the United States. This one, from a Canadian standpoint, tends to be quite conservative and still recommends skin testing more frequently than I think necessary. And so I wanted to switch gears a little bit and just bring quality improvement in healthcare into the picture. So this is really the why for all of the work that we've done after this point with Firstline. And so quality improvement has various definitions, but there are some common components. It's systematic, so it's not just something we do and see what happens. We require data that helps guide us through this change to help us know that we've done something right and that we're doing it properly. And what I love about quality improvement is that it emphasizes immediate action. So we're trying to do things quickly. However, we know that these things still don't happen overnight. So just keeping that in mind. And research and quality improvement, they sort of move hand in hand. So I do a lot of my academic work in QI. And what we're really trying to do is use the research we have available. So things like current state analysis, where are we at today? We have 10% of adults think that they're allergic to penicillin. And now we have tools that are validated. But how do we move these things into clinical practice and make it so that people actually want to participate? In British Columbia, we have a health quality matrix. And so the purpose of this slide here is to just show you that penicillin delabeling really targets all of the areas of health quality that we're trying to improve. And our work with Firstline helps us focus on the systems perspective so that patients in rural British Columbia or rural Ontario have equitable access to penicillin delabeling from a variety of healthcare providers. They're not waiting to see the specialist in the big city 2 years from now. And we want to do this efficiently as well because everyone's busy and we need to do this in an efficient manner so that it takes less time out of everyone's day if possible. In quality improvement, we do these maps. It's called the patient journey map, where you sort of like draw out the patient journey from when they get sick to when they get the label and what happens afterwards. So we don't need to go through this, but the whole purpose of this map is to identify areas for improvement. So I've circled in green areas where patient could be labeled with a penicillin allergy. And the bottleneck. So the bottleneck is me, the allergist, and all of us. There just aren't very many of us, and there's just not enough time to get these patients in to see an allergist and have their penicillin allergy risk assessed, especially if most of them, again, aren't allergic. And so back when we created this manual decision support tool, it came to me and I thought, wouldn't it be great if we could just use an electronic algorithm? All the answers are, some version of the same, and there aren't that many risk categories. So we had our research assistant, Leanne, create this really basic Excel sheet, and we just put all of our patients and the answers through the algorithm. And we found that it was more reliable than a human and their intrinsic biases going through this manual algorithm for identifying the low risk patients. And so we're able to find all of the low risk patients and more with no false negatives and without the need for allergist assessment or skin testing. And so this was really exciting. But we needed help because as the Firstline people, like Kiara at least will know, we have no experience in tech or how to convert this into something that other people can use without doing a lit search and pulling the paper up on their computer and printing it out. And so back when it was called Spectrum, we approached, the Cyrus and Mike Long, and we said, this is our idea. Can you help us? We already have a good relationship with our institution, and they thought it was a great idea. So we created one, and by May 2021, we had a first draft. We had a lot of stakeholders involved from many specialties, family physicians, pharmacists, health authority leadership, and we ran it through a test cycle and then took all of their feedback and made it better. And so by September of 2021, we were able to actually launch the delabeling tool. And thereafter, we started our second test cycle where we're looking at the data we're collecting to see if it's actually what we think we need, and we want to make sure it's meaningful data that we're collecting. And so this is what the delabeling tool looks like. And at this point, I'm just going to stop my share and try and do a demo that's live. And so this is the BC Women's Hospital version of the tool, but this is exactly what it would look like in anybody else's tool if you were to port it over. So you click the delabeling tool, and what it allows a person to do is access the tool in real time. So you can do a point of care assessment. So the patient could be sitting in front of you for some other reason, and they would say, I have a penicillin allergy. You can say, well, wait, let me just pull up my Firstline delabeling tool and we can see what your risk is. And so our first question is, are you using this tool for clinical care? Because from a data collection standpoint, we want to make sure we're collecting meaningful data and not the data from everybody test driving the tool. So for this presentation, I'm going to say no. And so the questions are right up on the screen. Is the medication being avoided even if there's no personal history of a reaction, such as a family member being allergic? So we could say no. Has the same medication been taken again and tolerated? And for example, we could say no. It'll take you to the next question. Has an allergist previously diagnosed the patient? No. And so we are trying to separate the data a bit according to patient category. I see a lot of children, so we can click on that. And then it will ask you questions about timing, and you can select the answer. So for our patient Anna, her rash started more than 1 day after she started the amoxicillin and more than 2 hours after the most recent dose. And her rash lasted 3 days. And she had a maculopapular rash and no other symptoms. So we click done. And now everything's been encoded in the background and all of the answers have been put together. And now we have a patient that is indeed very low risk for penicillin allergy. And so what's unique about our tool is that we also have suggestions for management, which is where people feel very uncomfortable. So we have multiple options. You can just prescribe again. There's no need to do a test dose, but I think there's a very huge psychological sort of safety component where people need to see that there's no reaction to a challenge dose in order to feel that there truly is no allergy. So you could do a challenge, and we have some guidance below as to the dosing. Or if you are very uncomfortable, you can always refer to an allergist, and that is certainly okay. There are other, it's a bit like choose your own adventure. So you could definitely end up in a high risk category. And in that case, the recommendation would be to refer to an allergist. Other questions I get are that patients who are adults often can't remember this level of detail. And so we do have an option for that. Does the patient remember details of the reaction? So if not, really, no. If it's been more than 10 years and the symptoms were very mild and they didn't require a hospitalization, then they are very low risk as well for penicillin allergy. I will just go back and show you what it looks like for possible allergy. And so it's just like this big red bar, and it tells you that you should avoid, send to an allergist. And in our tool, you can click in and it will give you recommendations for alternatives. And so that's how the tool looks. I'm going to stop share and go back to my presentation. One thing that we really, really wanted was that this tool could be accessible by everyone. Not all institutions have access to Firstline, which I think is unfortunate. But the thing is, there are so many practitioners out in the community pharmacist, community pediatrician, family doctor that really should have access to this tool. So we built a website, and this was the brainchild of a resident I work with, Patrick McKernan, and we have 2 wonderful medical students who are helping to maintain it. And on the website, if you scroll all the way down to the website, to the landing page, you can access the Firstline tool from there for free. So anybody from home can do it from their practice, can access it. And I think that's the real strength of this tool. And the partnership with Firstline is that everybody can use it. And so we're really proud of our little independent website. It's a great tool, and it has a fantastic tagline. I think that'll be easy for people to remember. And so with our second test cycle, we did sort of bone up with the analytics, and Kiara-Lise has worked really hard to restructure it. And so we have launched the delabeling tool version 2, and this is the one we're ready to share with everybody. We're satisfied with it. We've run it through multiple iterations. It's been tested hundreds of times. And so now we're just onto the spread component of drop the label. Within British Columbia, we have formally spread it to the Women's Hospital, Children's Hospital, the BC CDC, Victoria General Hospital on Vancouver Island, and some community pediatrics clinics. And we're onboarding some family physicians in rural BC, the Royal Columbian Hospital, and we're bringing some physicians down from Prince George as well to see some of our delabeling programs and help them develop their own, which is really exciting. A bonus of my work, and this is taken from Squarespace, is that you can see that our website and tool hopefully have been accessed from other parts of the world as well. So Alberta Children's has adopted the tool, and IWK has adopted our tool as well, which we're so excited about. But people have accessed our website and tool from the UK and Australia and Ireland, which is kind of cool. So I can't wait to see what this map looks like in a couple of years. We have some preliminary data, so it was a bit challenging actually to extract the data and separate the clinical from the non-clinical data. And so this is, I think, an underrepresentation and quite conservative in terms of numbers. But from September 2021 to May 2022, we have for sure had 360 patients screened. A whopping almost 30% of these patients are identified to be not allergic based on history alone. So these are the ones who are avoiding just because of a family member or have had the medication again or had skin testing in the past and it was positive. And then we have 65% who are in the low risk category, and between the low risk and not allergic category, 93% of these patients have had their allergy label safely removed. And at least 82 clinicians have indicated that they're going to conduct a supervised oral challenge of the antibiotic in question, which is really nice for us as well, because I think for physicians and pharmacists, this is the biggest hump to get over, this sort of anxiety over giving the medication, even though someone says they're allergic. And so for the take home, I'm hoping that we sort of, reiterated that penicillin allergy delabeling is really important because it can improve health outcomes, and that risk assessment and management is easy and can occur in most clinical settings. And now we have a tool for you to use that I think that you can be confident in because it's evidence-based. Most patients don't require specialized skin testing in order to delabel penicillin allergy, so this truly can be done in most settings. And anyone who can apply a label of penicillin allergy can also take part in delabeling, and this includes patients and families. We have this whole other quality improvement arm targeting patients and families, which we are working on because as healthcare providers, we can't do all of this work on our own. I wanted to acknowledge all the people that have been involved in developing this tool. There are so many people. Like the Firstline team has been amazing. The medical students, Brian and Justin, and Patrick, who's the resident. I can't pay them. They donate all of their time. It's pure enthusiasm. And then, of course, the wonderful specialists that I work with, and the pharmacists, I give a huge shout out to because they help drive this tool. They're very meticulous and had 1,000 great questions that the physicians weren't able to pick up. So thank you for that. And we just keep adding people to the team. So if anyone's interested or has questions, just feel free to reach out to us. And then I wanted to acknowledge my funding sources and also the Hudson Scholars Program, which gave me dedicated time to work on this project over the last few years. I don't think it would have been possible in this timeline otherwise. So thank you.
Thank you, Dr. Tiffany Wong, for this very informative presentation. Really great work on the Drop the Label project. And we also can't wait to see, where it spreads and how it gets adopted in all these different areas. It seems like we already have a question for someone. So
I'll pass it over to our participants.
Hi, Dr. Wong. It's Martha Debian. Fantastic talk. Thank you so much. I'm an adult infectious disease doctor here in Danbury, Connecticut, down in the States. And I wanted to share that I had done some very similar work while I was at Dartmouth a couple of years ago. I'm really, you're speaking to the right team here. I think it's a wonderful project you've done. So we actually published recently our study that looked at basically what you've described, almost always skipping the penicillin skin testing in patients with appropriate history, and that includes history of unknown reaction. And we've had similar results where nearly everybody tolerated either the dose challenge or going straight to a similar side chain to beta-lactam. So I think this is really important work. In my experience, the two barriers that I came up with were convincing physicians that this was a reasonable thing to do, despite the glaring allergy staring at them in the patient's chart. And then similarly, what to do after the test evaluation. So what we had run into is either the allergy would be removed altogether, and then 6 months or a year later, patients would be readmitted and the allergy would be added back to the list. Or we were actually updating the allergy to kind of try to reflect that the patient had successfully completed the dose challenge based on their history. I'm curious if you have gone into either one of those issues with your project.
Yeah, great question. Thank you, Martha. It's a challenge, and this is why it's a team effort, and why the sort of quality improvement and follow-up aspect is so important. So I think we do our best, right? Our pharmacists are really well trained and really enthusiastic about giving like a big speech about you're not allergic, it's okay, it's safe. We give documentation to the patients and families to bring to their community pharmacists, because not all electronic health records connect. In fact, most of them don't. And so we have to target multiple sources. So they will bring their paper to the community pharmacists and they will delabel. And pharmacists can also remove the label from our provincial database. And so I realize this is very local. But I guess that's the beauty of this work. It's different in every setting. So they'll remove it from the provincial database. The community pharmacist will dictate a note to the family doctor. So hopefully they'll remove it from their EMR. And then I work in a hospital, we will remove it from the hospital record. We are doing away over time with paper charts, thankfully. So we don't have that problem as much anymore. But there's always going to be the family that remains a bit anxious, or the child or adult that shows up again with a rash. And so it's a work in progress. And that's why I think it's so important to have pharmacists engaged as well, because often they're the first point of contact in the community. And just to keep touching base with these families and making sure they feel reassured. And that is a bit resource intensive. And I don't know that there's a really great solution to that other than targeting patients and families, which we have been doing with infographics, and the website too. We're starting to really bone up with patient resources.
That's wonderful. I think it's such a great approach to focus on education. That's great. Thank you.
So it looks like we have a couple more questions popping up in the chat. The next person was Jason. Jason, did you want to go over your question again? And I think Carolise could probably help answer this one as well.
Hello, everyone. So I work in Saskatchewan, and we have the Firstline app for the Saskatchewan Health Authority. So I think this would be something very useful for us, because that app, since it goes across the province, can be used by any of our community physicians as well as inpatient at any of the hospitals. So I guess the big question for me is, how do we get that going on our on our app?
Yeah, so I can definitely speak to that. So just a quick introduction. My name's Carolise. I'm part of the content team here at Firstline. And as Tiffany mentioned, we've been working on this project for a few years together. So currently the delabeling tool is not in the library just because the data structure is so complicated, because, obviously we want to make sure this algorithm is functioning properly, and that requires a lot of different, screens and such. But if you want to, port it over into your client database, you just contact us, email us at content@firstline.com, or you can email me directly. I'm sure Holly has all of your contact information, and I can put my email in the chat afterwards. But you just email us, let us know know, we're happy to copy that over for you. The beauty of the Firstline app is the localization. So if, you know, Tiffany was mentioning all the different like BC PharmaNet, like delabeling forms, things like that. If you have anything like that over in Saskatchewan, we're happy to make those edits, make those changes for you so that you can help your physicians and, you know, pharmacists, whoever's making this choice, make that easier for them, basically. So yeah, that's basically it. Just send us an email. We're happy to help.
Awesome. It's so nice to hear that people are interested in helping that spread for Dr. Wong. We do have another, oh, sorry, Jason, was that all the questions that you had? Perfect. And we do have another question, and I think that's from Sabrina. And Sabrina, do you want to kind of go over that question? I think this one's for Dr. Wong. Oh, that's okay. Here, so let me read out the question for Sabrina. So the question was, were oral challenges mainly done as an outpatient once patients were discharged, or did you have resources to perform oral challenges as inpatient?
Thanks for your question, Sabrina. So we do have an inpatient team, and that, yes, so we do have inpatient resources, but that's just for the inpatients. Most of our challenges are done in the outpatient setting. So in our allergy clinic, we're completely outpatient. Everyone else that participates in this is outpatient as well. We have a community pediatrician who's doing them in her own office. I'm really excited to see that there are rural family physicians engaged as well, because that's clearly a very outpatient setting. And all you need is the amoxicillin. And so you can either give the patient a prescription or stock it in your setting. Make sure you have the right dose, and then you give it to a low-risk patient, obviously. And we have them sit in our waiting rooms for somewhere between 30 and 60 minutes. I think it's prudent to make sure you have equipment to treat allergic reactions, but I have had zero in the last few. I've done hundreds of these, and not a single patient has had an IgE-mediated reaction. And I think it's partly because the allergies are uncommon, but also because we're doing these risk assessments. So we're not just giving it to everybody. We select these patients very carefully.
Perfect. And Sabrina, if you have any follow-up, you can type it in our chat, or if that answers your question. Perfect. And did we have any more questions from the rest of our participants today? Okay. And so
wait for more questions. I was just going to say that I think the one thing that has been something that I didn't sort of anticipate is it's like nice to have the tool available, but it's also important that there's ongoing recognition that it is available. So we could port it over, like here at least could do all the work and port it over, but I think there just needs to be this ongoing conversation about penicillin delabeling. And you don't have, like, the tool's great. We love it, of course. You don't have to use it, but it is something that's very easily accessible. And the more people that hear about it, that talk about it, I think the more patients will be delabeled. And in fact, there's an aspect of primary prevention as well. So if a lot of people out in the community, lay people, hear about this, they will start to know that just because there's a rash, it doesn't mean there's an allergy. And maybe that'll be the impetus to go see their pharmacist or their family physician, and then further counseling can ensue, and maybe we can prevent these labels getting put on in the first place.
absolutely.
I think that is exactly what I liked about this, just hearing that. So I'm not a clinician myself, I'm a researcher, but Melissa Cusi, who's on the call, is our antimicrobial stewardship pharmacist in Regina. And this is something we've talked about, is like, how do we get this going in hospital and or in the community? And so I really like having a tool like this, because it, even just helping people identify those very low risk patients where if they're in the hospital anyways for something else and they have an allergy labeled, I mean, that's something we could have pharmacy students go and start that process with the care team and just say, hey, we're going to do this, and they can connect with the attending physician and stuff like that. And, it's something that seems very low risk. And then they're in the hospital anyway, so they can be monitored for side effects or, whatever outcomes and stuff like that. So I think that's great. And it starts at a very simple way to start promoting that conversation within the hospital. And then hopefully, like you said, as you continue to promote that tool, it just spreads into the community. So yeah, I think this is a fantastic resource.
Yeah, absolutely. And I just wanted to sort of touch on something Martha said too. It's this idea of culture change, right? It's just getting people over that, like, it's okay, it's going to be fine. So I have found that a lot of people are quite anxious to begin with. But it just takes a couple of patients. You just give them medication and you sit there, nothing happens. And then people start to realize that it really is okay, that this is truly low risk and there's no need to be worried. And I think it's a bit slow, right, to begin with, but soon everybody starts to realize that these patients really do there's a huge benefit with very little work.
Yeah, I love seeing this kind of webinar where we do have people from all these different areas, some in Canada, some in the US. And so hopefully this is something that can help introduce and have that spread as well.
If I can just add one more comment, just in case this was crossing anybody's minds, both in the ambulatory setting as well as in the hospital, I have found that it is very helpful to have short little didactic sessions towards nursing as well, talking about a multidisciplinary approach here, really kind of discussing what the indication of the project is, what the rationale is, why we think it's as safe as it's going to be and as successful as it's going to be. That has really smoothed out wrinkles in at least the nursing part of this care, because especially in the hospital, there is a lot of nursing oversight for these test dose. They're not in the room for the entire hour, but they're sort of available and they would be the first person to be contacted, at least in our program. So it's just kind of helpful to kind of touch all bases of those involved.
Yes, absolutely. The nursing, I think arguably have been the more anxious group of people, and it's not because they don't understand evidence. They definitely do. It's the training, right? Like they are very careful about allergies, as they should be, and so it's really hard to sort of separate the ones you should be worried about from the ones you aren't. And these risk assessments, I agree, need to be part of their training, but at the very least, having these ongoing conversations and explaining to them what we're doing is really important. I've been to the ward many times, and it's usually the bedside nurse who's advocating for the patient, who's just like, why are you doing this? The patient's allergic, it's on their chart. And then once it's explained, it really does seem to put people at ease, but it takes time and experience.
Okay, wonderful. And just one more time, was there any further questions from anyone we haven't heard of? Anyone want a chance to say anything? Okay, well, thank you so much for everyone for joining. Thank you again for Dr. Wong for putting on this great presentation. The Firstline, I put the content email into the chat, so anybody who did want to adopt that tool can always email the Firstline group. We do also have Dr. Wong in our Firstline community, and she has already started a thread about her project. So anybody else who has any kind of like questions and wants to continue this conversation in the community, I'm sure Dr. Wong would be happy to answer any questions there.
Thank you so much, everyone.